Hello everyone and welcome to our project showcase event. Thank you all for taking the time to come and join us to showcase this wonderful project that so many people have been a part of, and we're really proud of it. So we're really excited to share and learn from the outcomes and where to next as well. So my name's Shyla and I'm the CEO of Palliative Care Queensland. And today's event is about our project called PalliChat Brisbane South. I'd like to start this event by acknowledging the traditional owners of the land wherever we meet today and pay respects to elders past, present and emerging. And we extend that respect to any Aboriginal or Torres Strait Islander people that are here today in today's webinar, and also acknowledge any sad news or sorry business that's happening on the lands and seas around us as well. Palliative Care Queensland is the peak body for palliative care across the state. We believe that the way we care for our dying is a significant indicator of the kind of society we are. Our organisation has three priorities: that all Queenslanders are able to live every day until their last, all Queenslanders are able to have a dignified death regardless of illness, age, culture or location, and all Queenslanders have access to a supportive social network at the end phase of life and the choice of quality palliative care. So for this project, I'd particularly like to extend our gratitude to Brisbane South Primary Health Network, and it's wonderful to have Eden join us today to share some of the background of the project. So Brisbane South do commissioning and other activities, and also a lot for their local community and their local region as well. And I think this project, more than anything, really demonstrates the way that they think differently and think out of the square, and are just doing a great job with their community and working so well with their palliative care and health services, their community, their primary health services as well, the interagencies around there as well. So it's so great to work with Brisbane South, and really big kudos for them to commission such a great project. So thank you. Okay, so housekeeping, like all these sessions, we're pretty good at this now, I'm guessing, for most people, but I'll do it anyway. Essentially, we'll do a Q&A session at the end. So you've got in your Zoom, either on your screen or on your phone, wherever you are, your iPad, there's a Q&A area and there's a chat area. If you've got any questions, you can pop them in the Q&A area. You can also put them in chat, and we'll try and just watch both and monitor that as well. So after this event, we'll send everyone a copy of the final report of the project, and we'll also send a brief evaluation. So I think a lot of people are used to evaluations now. We really appreciate you taking the time to just complete that. It's only short and sharp, but it does help with everything that we do. And also acknowledging that the topic we talk about when we talk about palliative care, serious illness, dying, death and grief, that can bring things up for different people, different emotions. So there are different support services out there, and there's particularly Power Assist, which is available 7 till 7, 7 days a week, online, or a phone service as well. All right, so let's practice our little housekeeping things. So first of all, we've got a chat function. So have a bit of a look there in your bar, I guess, the chat bar there. And if you can write in the chat there about your First Nations country, where you're from, or your postcode, or the suburb even is another way to do it. So for me, I'm in the land of the Turrbal and the Yagara people here in Brisbane as well. So this might come up. If you can pop that in there, we'll just make sure the chat function's working, so you'll see that. Lovely. I love this part of webinars because you just see the broad reach of the people attending, and we did know that some people are attending from different places in Australia, different places across the state, and also local people in Brisbane South as well. So wonderful to have such a range of people, and great to see everyone. Many of you we have touched base with before in different ways, which is lovely, and a lot of you have actually been involved in this project as well. So thank you so much for being a part and taking the time to join in now as well. So let's talk about today's showcase. So today's event, we're going to go through different stages. So we'll first start with Eden, who will talk about the background of Brisbane South and the process of commissioning this project and what the purpose of that was. Then I'll walk through the background and what we call the chat aspect of the project. Then as part of the chat aspect, we engaged Anne at Health Consumers Queensland to do some kitchen table discussions. So she's going to share some great information from there. And then I'll talk about the other aspects of the project, the learn, connect, and then what next and where we go. And we'll finish up with a Q&A at the end as well, so a question and answer session. So you can ask them anytime during that. You can put them up on the webinar anytime throughout this webinar, and we can answer them at the end during the question and answer, or you can wait till then and put them up as well. All right, so I'd like to start now by introducing Eden. So Eden works across 2 teams at Brisbane South Primary Health Network. She's a program coordinator for palliative care and multicultural health. In her palliative care role, Eden focuses on leading the key initiatives of the portfolio, ensuring integration across the systems to help meet the health needs of high priority populations in the region. She does this through strategic planning, design and planning, building strong partnerships, and utilising commissioning approaches that enable the successful achievement of the palliative care portfolio, but most importantly, better consumer health outcomes. So I'll hand over to you now, Eden. Thank you.
Perfect. Thank you, Charlotte, and good afternoon, everyone. Before I start, I'd also like to extend an acknowledgement to the Aboriginal and Torres Strait Islander peoples of this land on which we live and work, and pay my respects also to the elders past, present and emerging. I thought I might start just by giving a little bit more of a background of the role of the PHN and in terms of the journey of commissioning PalliChat. So most might be familiar that there are 31 PHNs, as Charlotte has mentioned before. And our role focuses on supporting primary care in many different aspects, but sometimes people are not really familiar with the role that we hold as a commissioning body as well. And so as part of that role, our job is to look for local service gaps and service needs and plan approaches and interventions to help meet those needs. And so as part of commissioning the PalliChat service, we had understood quite a lot about our palliative care sector and just wanted to ensure that we were still trying to stay in tune as much as possible with our community and what was needed and what they had identified in the, as you know, as a big challenge or barrier for them to access quality palliative care. And so the planning for the PalliChat service actually commenced late 2018. Whereas a team and through our health needs assessment process, we had identified the need to commission a local service that could support a community service aspect, but we weren't quite sure at that point what that looked like. And so we needed to go back and do a bit more consulting and engagement with not only our communities, but also our key stakeholders, which that process started in 2019. And so from that consultation and engagement process, we were able to identify 5 key service outcomes that were also aligned to our PHN commissioning priorities. Service outcome number 1 was to improve the access and uptake of palliative care and end-of-life care planning amongst our older people in the Brisbane South region. Number 2 looked at improving support for older people accessing or navigating between aged care and or palliative care end-of-life services within the region. Number 3 looked at increasing awareness of palliative care and also end-of-life care initiatives. 4, it was identified that we needed to look further into the evidence-based approaches that support care for older people and their closest supporters. So looking at public health approaches such as the peer-to-peer models and lived experience being included for carers as well. And last but not least, finding a way through this commissioning process to build community capacity through leading initiatives that could recognise and apply person-centred principles such as compassionate communities, asset mapping, and would also contribute to the evidence base to support cost effectiveness of supporting at-home palliative care. So through those consultations, those were the key outcomes and the purpose of why we set out to develop a model that would be unique, and also a very different way of us approaching our commissioning. As most people would be familiar, a lot of our commissioning has sat quite heavily in the clinical space, which is not to discredit the clinical space at all, but there was a real need to look at what our consumers were telling us, and that was also to support a non-clinical approach. And so a big part of our work was to look at, well, actually, because both play a key role in supporting our communities, how do we look at something that's going to bring these two worlds together? And essentially, we had identified with our community and our lived experience consumers two core service components that would be prioritised in this piece of work. So one of the first service components was the connector aspect. So looking at how we could integrate all systems, social care systems based on the needs of the clients, and the ability to connect to existing resources and supports available in the early intervention or before experience or before, sorry. And so then the second part of that was looking at the peer-to-peer and lived experience aspect as well. And so through our community engagement groups, the peer-to-peer and lived experience aspect was actually one of the most important aspects for our groups that had been identified over and over again through our conversations. And that was mainly because they wanted to be able to continue to connect beyond, the end of life journey, and also still be able to share their experiences with other people in the community to essentially be able to let them know that they weren't alone in the palliative care journey, and that beyond the dying part of palliative care, that there was still support there for them. And so as you can see, the task was a major one at hand, and so it wasn't an easy feat for anyone who would put in a tender. But as per our usual commissioning processes, we did put it out there and we waited. So we were lucky enough to have an organisation such as PCQ tender successfully and understand the ask, and just had their proposals, project plans and frameworks in place. And we were really fortunate that they were already working within our communities and had already established local networks and partnerships. I just wanted to mention that during the point of designing and planning, at no point did we anticipate a global pandemic. But as things fall out of our control, and also out of PCQ's control, we were able to still push through and achieve what needed to be achieved through the PalliChat project. And so I would just like to take this opportunity to thank PCQ and Sharla and the team for their flexibility and adaptability to ensure that there was limited disruptions to the project and the community services. I won't go into too much more details because I don't want to take away from the showcase and the wonderful learnings that will be shared through our session today, but I'm sure that you'd be just as pleased as I am to be able to hear about the great and wonderful outcomes that have been achieved, and would also join me in congratulating PCQ and Sharla and the broader team for the great work that has been done despite the challenges of COVID. Thank you.
Eden, thank you so much, and thank you. Like we said, you can see Brisbane South PHN really thought out of the square and really looked a bit differently around this, and we'd really thank you for the opportunity from our side to play in this space almost in a way. We were very privileged to do that, and I think you can see, we'll go through some of the activities and the outcomes that you can see here. I'll also mention to everyone that there isn't a report, and this is a summary of the report that we'll go through today. So rather than sharing this presentation and some notes, we'll share the report with you, and that's the aim, so that the findings can be taken and absorbed and utilised in different ways and take this forward, because the project doesn't exist in isolation. It really needs the community to come together, the services to take the learnings, the activities forward and continue these learnings in Brisbane South, but other jurisdictions and other areas as well. So that's why it's so lovely to do this session today. So I'll start by walking a little bit through the project. I thought we can't start by not acknowledging Julian Abel and his team over in the UK, who really inspired us for this project. They run a project called the Health Connectors MENDIP project, and it's funded by the NHS, and it's in a community in the UK that's quite a small, reasonably affluent community there, and it works really closely with the primary health teams. So we were inspired by this, but obviously we adapt it quite a lot to meet the local needs of the Brisbane South area. But just really flagging that for everyone, if you haven't seen their website and looking there as well, that's a really great tool to understand the background of this project. And Julian spent quite a bit of time at the beginning with our team sharing his learnings as well. So we're happy to do that with lots of other people if you're thinking of going in this space. So the next slide, please. This one talks about our theory of change. So the beginning of every project, we do a theory of change. Why are we investing all this time? What are we actually going to do? And what does that want to look like at the end? So we try to do this across all of PCQ to look at the social impact of activities that we do. So really, what was the problem we were trying to address? Eden really talked about a lot of those there with part of the commissioning process in this space. We also realised that some of the work we did back in 2019 with holding compassionate community conversation series in the region really demonstrated that there were some outcomes that needed to be continued within that space. So we used that as well as a baseline. And then we took some asset-based approach, which really is a public health method, which really looks at the fact that the community has existing assets. Let's work with those community assets and extend the project rather than come in fresh and see the community as not having existing assets. We wanted to really cultivate capacity of both the services and community. So you'll see as part of the tools of the project, we really worked with both areas. And we wanted to improve how we evaluate and then share learnings with activities such as this and a public reporting of the outcomes of a project as well. So how did we do it? We started with mapping. We did a lot of mapping of the local community, and we worked a little bit with La Trobe University in that space. And we mapped a large number of local services and supports, looking at different aspects of what that mapping might look like. So looking at different themes of that mapping to be available so that we knew people don't always say palliative care. Often they look for grief services, or they might look for emotional supports or funeral services. So we had to think differently with the mapping and try and think of anyone that might be involved in serious illness, dying, death, and grief. We then developed the chat aspect of the project. So this is how we connected with individuals and groups in the space, and I'll walk more through that. We did the learning aspect. So this is community-based public education. And we did the PalliLearn activities and also some intensives as well with last aid. And actually Brisbane South was the first, as part of this project, was the first place that we held our first last aid course in Australia. And it's because Palliative Care Queensland is the first group to bring last aid to Australia. It's an international public education course. So that first session was held in Brisbane South. So we're very proud of that with Brisbane South PH and help enabling that to happen. We realised that connections are really important, that nothing happens in isolation. You need to work with the existing assets and services and supports. So really making connections is critical. And then if we can share these as publicly as possible, the outcomes of this report, like what we're doing now. So the theory was that this would result in, increased confidence to start discussions, increased awareness of what services and supports are available, increased ability of the community members to help their family, friends, neighbours at the end stage of life, an increased understanding of palliative care, particularly in relation to advanced care planning and bereavement. Often people don't think of them as different components of palliative care, but that is a big part of palliative care as well. An increased knowledge of the reality of death and that it's an important part of life. And by knowing this and thinking about this, it can actually help you to prepare for your future. So the theory of having these outcomes is really big picture, looking at, does this improve quality of life for people? Does this improve systems and access to supports? Does it increase compassionate communities? And ultimately, are we changing the narrative towards positive dying and improved well-being of our society? Now, obviously, those last two lines we can't measure in this very small project time. Technically, the project went for a little bit over 18 months. So really the basic outcomes were measured as part of it, and we are happy to say that all of them did improve. So we aim to increase all of those 5 components, and they did improve as part of the activities that we did. But we can't actually get down to the later levels, and potentially that's where future activities that you can all take forward in the community to continue to try and improve and increase quality of life within the community as well. So next slide, please. So the other thing that underpinned the project was the circles of care. So this is adapted from, again, Julian Abel, who inspired us over in the UK. He's the founder of Compassionate Communities UK. So he created this model with a number of other people. And essentially, this is the core to the project. We tried to embed this in all aspects of the project. We taught about it in the learn aspect. In the networks, we really wanted to connect the different layers of the circle together. In the chat function, we did a lot of mapping of people's circles of care and understanding what that means, because often people just start from the middle and they think of the person and the carer, and then they jump to the red layer, which is the services. And that's where they think their circle of care, that's all that people have. So it's really important, and what we really wanted to emphasize throughout this project is that there is also an inner network, an outer network, and a community that is around you that can contribute to people's circles of care. And actually, when Anne talks about the kitchen table discussions, I think that really highlights the value of these multiple layers, and people working in health and social and community sector to really think about the layers around people of potential supports and opportunities to engage with their care. So it doesn't always have to be a paid funded service. There's different ways that you can think about this space, because people definitely want to help and they want to give. So next slide, please. So the background of the project, essentially we did some key stakeholder interviews and qualitative analysis of those interviews. We also did some kitchen table discussions at that point to understand what we have pitched as part of the project commissioning, understand what would that look like? What does that fit with what the community wants and needs? So this is summarised throughout the report, but really some of the activities of the key stakeholder interviews really talked about some things that we should focus on. So we should focus on promoting a broader social support through increased community awareness and connectedness. We should build community capacity through empowering the demedicalisation of social care with informal supports that complement formal services. So that mix of the informal and the formal is really critical in how we work together. Again, like what I was saying around the circles of care model. We should raise awareness of existing services and supports. Again, an assets-based approach. Enable effective community navigation. We also call this signposting. And you can see the little picture on the bottom of this, which again, reference the signposting and supports that's available. Build professional and community capacity, and raise awareness and build capacity in formal and informal settings. There's a lot of these different discussions that happened, and we like to think we touched on some of these, but really encourage people again to take these learnings forward, because so much more can always be done with this. Next slide, please. So this is what we came up with. The concept was called PalliChat. It took us a while to come up with the name. I think the lovely thing about the label was a chat, a yarn, a chinwag. You know, it was that really, this is natural. This is what we all talk about, and we do that in life. And so it's just to continue those conversations and have that circle of care around people in that space. And we focused on different angles, which is that chat, learning and connecting as part of the project as well. So I'll walk you through a little bit more about that. Next slide, please. So the chat part. So we started with, originally in the project, we thought about having this as a one-on-one chat with a phone line and face-to-face with people at their house, sort of a clinical type support, but not a specialist palliative care support. This was very much a generalist support for people. What we quickly identified partly might have been due to COVID, it could be due to other amazing services and supports that are already existing in this space, that really the key focus and the key difference we could make was around the group chats and the group supports. So that's really what we focused on. And we held PalliChat cafes in different community groups and community locations, cafes, but also libraries and other areas as well. And you can see here one of the participants said, I came to a PalliChat cafe because it's difficult to talk to family and friends about death and grief. One of the angles that was different with the PalliChat cafe from the death cafes, which are also a wonderful model in this space, was our PalliChat cafes were focused around the circles of care, constantly trying to bring everything back to that. So we're really educating community around thinking and mapping your own circles of care in everything that you do. And you can see some of the numbers there of the project, which are all in the report, but essentially we had 350 support chats throughout the whole project. 86% of these were in group settings. Like I mentioned, this was a key aspect that we learned as part of the project. We talked to our facilitators and our Palli Wellbeing officers that facilitated a lot of these amazing conversations, and they talked about what they actually discussed during these. The most common was social or community supports, bereavement, GPs, advanced care planning, and specialist palliative care. So it wasn't just around the health model, it was very much around what is that person asking for. Often the learning was that people started with the health questions, but if you delve deeper into it and started talking about circles of care, often they realize the solution is different to what they originally thought they were looking for at the beginning. So you can see some other information there that 87% of the support chats were signposted by our team to health services. 78% of these were signposted to existing supports or existing networks, and only 2% were signposted to new networks or community groups. So that really emphasised that people already have a great circle of care in place, but they often don't recognise it. So that's where signposting to these existing circles of care is a really great asset to consider in this space. And therefore they're recognising their own care assets around them as well. Next slide, please. So I'd now like to introduce you to Anne Curtis. Like I mentioned, she's from Health Consumers Queensland, and she did a great job with leading some kitchen table discussions in this space. I personally think this is one of the most exciting ways to do consumer engagement, and it's just so lovely to see these outcomes. So I'll just introduce you to Anne first, and then I'll hand over to you. Anne is the engagement consultant of specific projects at Health Consumers Queensland. Her work is focusing on enabling the voice of grassroots community to be heard on health-related topics, and does this through community-led kitchen table discussions and other methods. Over to you, Anne.
Thank you, Shyla. Hello, everyone. And I would like to start by acknowledging the traditional owners of the lands in which we meet today, and to pay my respects to elders past, present and emerging. And Shyla, thank you for the opportunity to work on this project. So if we could just move on very quickly to our next slide, James, thank you. Yeah, so as Shyla said, with the kitchen table discussions, they are an opportunity for consumers to actually lead consultation in their own community. So there are no professional consultants there, no health staff are there. This is a consumer takes the lead. They invite their participants. They choose the date, the time, the location, excuse me. They have a 2-week time frame in which to then facilitate their session. And how we do this is we, as our process, we remunerate our hosts for their time. We also give them up to $100 catering budget, because sitting in circle with food, refreshments is the most wonderful thing you can do. And as Shyla was saying, it's totally normal to be doing this. It's what we always do. And we also remunerate our participants, because hearing their voice is just so valuable. And in these circles, when they come together, they have an opportunity to actually hear from one another, to learn from one another, to share with one another. And sometimes it's the first time they've had an opportunity to actually tell their story. It's the first time maybe someone's listened to them, or they've felt safe to talk. And so they talk very openly together, and sometimes these sessions for them can be very cathartic and can come with amazing outcomes as a group. At the same time, what they're doing in these situations when they're actually having these discussions It's improving consumer health literacy because they're actually educating each other. So someone might know of a service that someone else doesn't know. Someone may know of a way to get to somewhere that someone else doesn't know. So they talk together and they educate each other. So that's the beauty, and it's an inclusive process. And we hear from very diverse groups and hard to reach people and the disadvantaged who wouldn't, and these are always people who wouldn't go into a normal consultation process. So they might not go to a focus group. They may not ever fill out a survey. So it's the consumer led, and that's the beauty of it. So thanks, James. Just moving on. So with this project, there were 2 projects and we had 2 kitchen table discussions for each one. And one of them was the Brisbane South LGBTIQ plus consumers. The other one that I'll go through is the Brisbane South Islands, or the Bay Islands. And also we had 2 hosts doing discussions there as well. And what we do is we give them a series of questions that Shyla brought together, and we only ever use 5 or 6 questions at a time. And with this one, what we did was that our host started by actually hearing stories, and the amount of stories that we heard was absolutely extraordinary, the amount of stories that came back to us. And then we asked, with the LGBTQI group is, do they feel supported? And was there any treatment disrupted in their time? Who provided their support? What resources, information, supports were in place to assist them to care for their loved one in relation to diversity? What was most useful? And sometimes, and this was a really interesting one, but sometimes people offer unhelpful help, usually not intentionally, but it's good to understand this space as well. And could you give examples of unhelpful help? And what supports, help, or resources or information do you wish had been available or you believe might be helpful to others in a similar situation, and why? So before I go into what came out of these, the kitchen table discussions, I do want to say that I know, Eden, you talked about, and Shyla, about this being a time of COVID and the impact of that. But when these sessions were held, it was the Brisbane floods, and I've got to say, our host did an incredible job to keep these sessions going and to get through them. It was, for some, a very difficult and challenging time. So moving on to the next slide. Thanks, James. So with the LGBTIQ project, I want to run through what were the key things that came out. And they said, no matter who we are, we should not have to do this alone. No one be refused their choice of lifestyle or beliefs. Invisible deaths should never happen. And they always talk about the need for bereavement care, but also spiritual care, and acknowledge the journey of the carer as well as the patient. They said clinicians to not continue to try different treatments when there is no benefit to the patient. And understanding that palliative care takes time and the person's comfort is most important, and this needs to be recognised by all staff. People rely on those closest to them and their friends for support, including physical support when needed. And so also being able to be there for a loved one at any time is important for both the patient and their family members and their friends. People really want someone to talk to. They want people to listen, support, and understanding from those around them. Visual and sensory stimuli is important for those in palliative care, and that should be considered when the palliative care rooms are being set up. They talk about a need for diversity training of palliative care staff, and understanding diversity includes people who are LGBTQI plus. More palliative care training, and in particular for new staff, and they felt that this was really necessary in many ways about how to work with patients. And more training for health staff in dementia care, but also culturally safe care. So James, thank you, move on. Next slide. Thank you. For them, having LGBTIQ plus community members as a circle of support is really valuable to them. And they talked about person-centered care is key. But they also talked about treating clinicians not being empathetic or giving time to the patient when delivering difficult diagnoses. And not just giving really quick, you know, like tap on the toe, this is your diagnosis, and walking out the door. They didn't like labels such as a cancer survivor, and they felt that that was not helpful, being called a cancer survivor. Giving advice that is not helpful or wanted. And they said sometimes support is not always available. What they would like is having someone to help guide you through the end of life process. And having someone to talk to, someone to help through the emotional aspects is really important. They want support those who feel they do not have a voice. And there are people who feel they don't have a voice. Knowing your rights as a patient is important, as is seeking a second opinion. Being willing to receive others' kindness, love, generosity, and expertise. Do not judge people who do not know what to do or say. They talked about inner city living is an advantage in comparison to people living in rural and remote regions because they have more access to care. And they talked about palliative care nurses are a huge resource. And they also said, stop calling patients love and dear. Family pressure that is placed on people in palliative care is an issue for some. And also accepting help when it is offered or reaching out for help is also something that they feel that is important, that not everyone does reach out. Not everyone accepts help. And that is something that needs to be considered as well. Thanks, James. Next slide. So they were the key outcomes of that project. So then we moved to the Brisbane South Bay Islands, and there's 2 kitchen tables. There was one with residents of Russell and Lamb and one from Coochie. And so again, we asked this time 6 questions, and again, starting with their stories. Again, asking, did you feel supported by the local government area, local community health, social community service when you needed it? Was any treatment disrupted? Who provided the support? And again, around resources and information, were they in place to assist you living on the island and caring for your loved one? Where did you find this information, and was it easy to access? And again, that question around unhelpful help. What supports, help or resource or information do you wish had been available, or do you believe might be helpful to others in a similar situation, and why? And finally, if you were in this situation again, what would you like to hear from someone who has experienced it before? And that it is palliative care. So thank you, James. So what they said, oh, I've got an extra slide there, so we'll move on to the next one. Thanks, James. So what they said is they talked about their first responders. And the first responders in all situations are volunteers, and they are highly valued by the community. And they talked about support is mainly provided by the community, and they felt with blocks from the system. Islanders rely on their own communities and families for support. They feel they have to look after themselves. They had concerns regarding Queensland Ambulance Service that they felt needed to be addressed. There's also, they said, a lack of understanding by mainland health professionals and others in relation to services available on the islands, and thinking that these services are there, but they don't actually exist. Access to pain management, they said, is an issue. And then they talked about the Redlands Palliative Care Service being an excellent service. And also there was mention of Marta and PA. They were also acknowledged for their service. Pathology service to Lamb Island has ceased. Oncologist and local GP provide support, but most support for patient is through a loved ones again. However, they did talk at times around where there was a GP or an oncologist who may have come onto the island and actually walked up to the home of the person that they were visiting, to the patient, and how that was really appreciated. They said there's a loss of support due to moving to the islands left one family struggling. The supports that they had in where they lived previously was not there anymore, and so they were struggling through that. Also, a lack of knowledge of services and how to know what or where they are. And individual islands, they said, were not always working together. So moving on, thanks, James. They said knowledge of palliative care availability and services would be really helpful for them. They said the islands need professional people available for emergency situations, and there is no structure in relation to accessing health service information. Patients are left to find their own way home on discharge from hospitals, and this is unacceptable. And someone talked about someone going home in their pajamas. Support systems are needed for families, carers, and the bereaved. And they said an ability to hear from someone who has experienced end of life would be most welcomed. And there is a need for GPs and pharmacists on the island to be the information hub for health information, and they would be the best outlets for that. They said when it came to that question again around what isn't unhelpful, they said after the fact conversations are not helpful. So when you're at a funeral and someone is, sort of making some comment to you, that is really not helpful to you. Unwanted approaches and unhelpful visitors who stress patients. Patients being asked inappropriate questions by a researcher was one comment that came back. And they also said they have a companion line which is provided to support residents, but many don't want support due to fear or being too independent. So due to fear of being moved out of their home or wanting to very much stay independent. And then there was a comment that said, although some people think that a brochure is not helpful, when you've had some bad news, if there is something to give them, you cannot take things in very well. You have to have written stuff. It's got to be there and it's got to be up to date. So that's the key outcomes that came from the 4 sessions in which I said were held at very difficult times with Brisbane flooding and torrential rain. And so thank you to the extraordinary hosts who did this work. And thank you, Shyla, for the opportunity.
Thank you so much, Anne, and thank you to the whole community that came together to facilitate and share that wisdom and knowledge and stories with us. I think it's really important to not only hear the good stories, but the challenges as well, and to consider all of it so that we can have lessons learnt for the future. I think it's such valuable feedback, and you will see in the report that there is a summary of that. So I'll quickly now walk you through the other aspects of the project. So we talked about chat. Now we're looking at the learn aspect. So in here, we looked at the PalliLearn model that PCQ has as our public education model. This has 8 basic training courses and 3 intensive training courses. Now, obviously during COVID, we had to pivot a lot to being online. We do currently still hold our intensive courses all face-to-face. So we did manage to hold some of those, but we were able to also hold online events as well. So next slide, please. So the some of the activities that we learned, or some of the outcomes of these sessions, we had a total of 428 people in the Brisbane South area participate in the education courses. And I do see some people online today that were involved in some of those courses as well. So thank you for continuing the conversation and coming along. So we held 84 community education courses in total, and that's 156 hours offered. You can see a little bit of a breakdown of which courses were offered. But I think for me, what I always love to look at is some of the take-home message or the feedback from the course participants. So a take-home message from the course today was that you don't have to be directly supporting someone, but you can help them by supporting their circle of care. Now, like I mentioned at the beginning, this project really aimed at looking at the circle of care as core to the project. So by seeing that as a participant telling us back this information, we know that we've done well in the project, and the facilitators of these sessions did a great job by enabling that. Someone else said, it was a great course. I recommend it to my daughter-in-law who's since completed the course. So it's great to see that ongoing feedback, but then also engaging participation. This is community talking to community, peer-to-peer, and this is great to see and hear. And there was lots of other feedback, which we'll share some more in the report as well. So next slide, please. We also looked at education webinars, and these are both health sector and community webinars. So we held a total of 14 webinars, and of those, 266 people attended. A lot of this is to share resources and information, and I think one of the lovely feedback we got there was, I'll definitely look up the Gwandalum project. This is a palliative care First Nations project, and let others in my workplace know about it. So that's, again, we don't need to hold all the resources. We can share and navigate and signpost people to others. So that's a real success of this project. Next slide, please. So now we'll look at the connect aspect. And this aspect was looking at building networks, facilitating conversations and hosting presentations. We did 292 of them in total. And 78% of the presentation evaluations said that their knowledge and confidence on that topic presented increased after attending the session. So that's a great success. Other feedback talks about great meeting and great resources. My take-home message, share the knowledge. Again, this is about empowering others to share and connect and know what's already out there and signpost others to other things. So these are the key purpose of the connecting aspect of the project, and the team did a great job in that space. Next slide, please. The other aspect that's always really important is awareness raising. So often you focus on the activities of the project, but you forget that the awareness is key aspect to this. So that can be done through marketing and promotional resources, but it's also through e-newsers, word of mouth discussions, flyers. Social media is a big part that PCQ uses as well. So we did a total of 27 social media posts, and the total reach of this was over 28,000. 159 people received the 3 project e-news that were disseminated throughout the project. And it's so lovely to hear about the look and feel of the project, which I guess was one of our particular feedbacks that we've had, is using the bright colours and using illustrations. People felt that they were very engaging. It's not something I'd usually expect to think about palliative care. So one project participant. I thought this feedback was great from one of our project managers. We arrived at one event in a regional location and only one person was there. The flyer and emails didn't seem to get to the community members like we'd hoped. The attendee there was enthusiastic and a community connector. She went door knocking and phoned her friends and families and colleagues, and we ended up with 10 people attending. It demonstrates the value of word of mouth advertising. And this is that lever approach that some people might be aware of, that really is around the key assets in the community, connecting with other assets. They're the trusted member of the community. And often if they say this will be a good activity to attend, people trust. Whereas sometimes services, they don't trust so much. So that's really where it's important to work with community members, find those leaders and those assets in the community and work with them, because that's how you get the reach and the awareness and engagement in projects as well. Next slide, please. So project outcomes. So like I said at the beginning, we had these 5 project outcomes or indicators we were trying to improve on, and every aspect of the project did say we did improve to a certain aspect, these elements. Obviously, it's only a 2-year project, so really seeing the big picture outcomes is not there, and it isn't a research project either, but it is great to see improvements in all those spaces. And I guess something we'd really encourage people to consider is using similar outcomes so that you can see collective effort in the same space. And sort of measure some collective change as well. The numbers there are really important too, the reach. 155 relevant agencies were mapped, 385 people participated in the chats, 545 people participated in the learning aspect, 365 people participated in the connection aspect, and over 28,000 people were reached during the awareness aspect as well as the projects. So they're great to see that awareness and reach and engagement of the project as well as important outcomes of the project. Next slide, please. And so all of this really coming together looks at the lessons learnt. We did a little deep dive, is the team looking at exact activities throughout the project. We constantly did cycles of reflection on activities, and these are some of the learnings there. We also presented these to the steering committee earlier last week, and we talked a lot about the project lessons learnt and recommendations as well that I'll share now, and they're also in the report. So we talked about mapping, looking at some of the aspects that we did, connect, learning, chat, marketing, all of these aspects, looking at these as key components of the project and how we can support that as well. So using colourful images and branding, using a desktop agency for desktop mapping of services is useful, but it's actually around how to train people to use databases really key as well. So there was lots of lessons learned there that we encouraged to share. Next slide, please. And so the final part of this is really invitation to action. And this is what I really encourage everyone today to think about and consider for the future. If you live in the Brisbane South region, if you don't live in the Brisbane South region, they're still very relevant. So this was our reflection of where to next. And we really encourage the community, which means services, supports, community members, agencies, everyone within the Brisbane South region, to consider the following 7 items when supporting people experiencing serious illness, dying, death, and grief. Focus on the carer and the circle of care. Recognise that the community wants to help. Use an asset-based approach. Understand that relationship building takes time. Integrate volunteering into care models. Localize your approach at the LGA level. We started with the 4 LGAs, but we realized that's quite a big distance. So we then moved to the Redlands LGA, and that was a more defined region. People know their LGAs from their own community and the conversations and dialogue they have with their LGAs. So that's really important. People often don't know it at the health service or the primary health network level. So start at the LGA when you're working with communities, and leverage off existing supports and organisations as well. So next slide, please. So it's great to wrap that all up in every activity of this project and share it and showcase it in this report. Now it's a bit over to you. Does anyone have any questions or comments or anything? Please pop them in the chat, the Q&A area, or in the chat, and we can ask myself, Anne, or Eden, any questions that you have in this space. While people are coming online, I might just ask Anne a question, if that's okay. So Anne, I might just ask, with the kitchen table discussions that you do there, what do you think is the most, what's the feedback loop to the participants of those? How do you share the outcomes, or where this valuable information goes for them?
What we do is, Shyla, we have a debrief session that we provide for the host if they wish to attend, and a briefing session. So what we do is we bring them back together and let them talk about their experience, but also give them an overview of the actual outcomes of the project. So they then take that information back to their participants. But of course, when we've, once we've got the, all of this together, we can just give them that as well, your report, and we will send it out to them, to the hosts, in the hope that they will then share that back with their participants. And that way, it's closing the feedback loop, but at the same time, they also know that their voice has been heard.
Well said, definitely. And I think that one thing I really recognise how well Health Consumers Queensland does that, shares that knowledge and feedback that we hear is that consumers just are really proud that their stories have been shared and that it's gone to different layers and it's gone to where it makes a difference. So really proud there. Lee, you've mentioned on there that around paediatric palliative care and how can we include that in this? So a little bit of background there is we didn't limit the aspect of this project to older people. However, we did focus there mainly. Now that's really because the PHN funding was around the older people area, and that was the key focus. But we did include in the learning aspect, talking to children about dying and death and grief and other aspects like that. But I do think this is an all of society project. These projects are for any age, any stage, and it's really important for everyone to be aware that no matter who the person is in the centre of the circle of care and what their age might be, the same methodology actually applies to everyone. That if you build a circle of care around them, then you will continue to support that person, their family, their services, but also support the carers and the family after they've died as well, which is a big part of that circle of care building as well. So I think there's a great opportunity to do a very similar project and just use a similar methodology in all different ages in this space, because no matter what age people are dying, it's a similar support network that people need around them as well. I can see a few other notes, which is great. So Trish, you asked if the presentation will be available. We're not actually sharing this presentation, but we will send you the report after. And really that has the summary of everything that we've talked about anyway in this presentation. So we will be sending that via email after. We've got some lovely feedback online, which is great. Someone's also talked about some ladies at their cancer support group spent their final days in hospital, even though one person tried desperately to get them home, but they couldn't. Where is this type of question answered? And I think it's a tricky time. I think one of the things is about what services are available, asking the local services. In the hospital, a key role that's played is the social worker. Ask the social worker questions about supports that people can get. They can enable people to get home if needed in that space. But it is tricky. We do work in a very challenging environment in palliative care. And PCQ advocates constantly that it needs more funding in this space to get extra resources and supports. But the team do an amazing job with what resources they have to activate care and supports for people. It's really important to remember that it's not just the funded services and supports, it's the community of care around them as well. We learnt about an amazing project that happens in the Brisbane South region where flowers are delivered from a local, one of the local nurses at one of the palliative care units collects flowers from her local community and they bring them in and one gets to every bed. So how could you play a role in connecting with your community and play a role in that space so that in the future, others have a circle of care and support around them as well? They're the things that we really encourage. If you do need support though, and you can't find a service, please do ring Power Assist. They are the phone line that does direct people to local supports and services as well. Karen's mentioned there online that do you have any ideas or suggestions how council can support the invitation to actions from this project? Oh, definitely, Karen. I think council play a considerable a role in the space of building compassionate communities. I think, to be honest, councils actually taught us so much in this space. Community development workers are so impressive with what they do. And really, it's about partnering with palliative care to put a different lens on some of that work that they do. But really, this social support is exactly the same, no matter if you're at the end of life, beginning of life, if you've got a fragile health situation, all these things. It's about building that circle of supports. I would encourage Karen and the local and the councils also in the Brisbane South communities to consider about being a compassionate city. So this is an international model and it's a charter to be a compassionate city. So it's a policy level that actually says that I'm committed to this with my community. And that's why you've got some time and support to focus in this area and it becomes a priority for your council as well. I think the other thing is just knowing circles of care, doing that constantly throughout your community development work and with other councils and neighbourhood. Maybe there's something you could share on your neighbourhood day or neighbour day every year that's particularly around this space. So think whenever there's an opportunity and you're doing other awareness campaigns, how can I put the lens of inclusiveness for people experiencing serious illness, dying, death and grief? All right, we've got lots coming through. Thank you, everyone. It's amazing. So some really positive feedback, which is great as well. So thank you in that space. It's really lovely to see that. And I think it's really important to emphasize the amount of people involved in this project, which is huge. And it was so fabulous to have them all involved. Someone there talks about a good way of introducing this subject to not only our own GPs, but to others in the area. I think it's just being brave to have a conversation in this space. Like we said at the beginning, and like the name of the project is, just start a conversation. That's so important. Just have a chat, a chinwag. You don't have to have the answer, but just start bringing it up because it's one of the only facts of life is that we will all die one day. So it's important to start that. And you can attend some more education sessions. We do have them going online and we make them extremely cheap so that everyone can continue to learn and grow in this space as well. So just bearing in mind the time, we'll just wrap up now and thank you all so much for your wonderful engagement and stories and messages there in the posts. And we'll just move forward and I just wanted to say really thank you to everyone. It takes a village to plan and implement a project. This project would not have been possible without our amazing staff and team that did all the main work. I just come here and talk about it, but they did all the hard work and they really share that with their community. They connected, they engaged, they really thought differently around this space. So a huge kudos to them and their wonderful work that they did throughout this project. Also, all our consultants that helped at different aspects of the project as well, the steering committee members that gave such great guidance and governance around the project. Thank you to Brisbane South PHN and the support from the Primary Health Network, and thank you for continuing to support palliative care and highlighting that as a needed area. You guys are really amazing, and thank you. And thank you to Anne and Eden today for helping to support this session, and also to James and Megan who are online in the back end supporting it as well. Thank you so much. But most of all, a big thank you to all the project participants, because without you guys, we really can't make the difference that we do in these projects. It's the consumers and the carers and the community members that teach us so much. So thank you for engaging and sharing your wisdom and knowledge with us. So what next? This is what the report looks like. You'll get a copy of this sent to you on email, and it's got a little evaluation link. It really shouldn't take more than 2 minutes. So please complete that and fill that out and send that back. It's just a quick survey monkey. If you'd like a certificate of attendance, just email us and we can send that to you. And like we said, we'll send you the virtual copy of the report. So the last slide, please. So just to wrap up with everything today, I just thought we'd close with our PCQ's vision, which this project really fits into the whole vision of what we do and why we do it. So the vision says, we want to hear all Queenslanders in the community say this. I live in a community where everybody recognises that we all have a role to play in supporting each other in times of serious illness, ageing, disability, dying and grief. We are ready, willing and confident to have conversations about living, ageing, dying and grieving well, and to support each other in emotional and practical ways. We hope that this project somehow enabled this vision to happen within the Brisbane South region and within you all, and I hope that you can take these activities forward and improve the community's way of supporting the people that are experiencing serious illness, dying, death and grief, so that we can all live, die and grieve well. Thank you all for your time today.